Good morning, everybody. I was really hoping that we'd be able to meet in person today or over Zoom, but I am still feeling pretty under the weather, but I wanted to quickly get through the rest of the chapter so we didn't fall any further behind here. So we are going to talk about some of the causal factors for personality disorders. Researchers are actually believing that personality disorders are on the rise and that they've increased quite a bit in the past couple of years in American society. We found that narcissistic personality disorders are more common in Western cultures. And part of that is because we are focused on personal ambition, success, and with the explosion of social media. They've talked about the possible connection between cultural emphasis is on impulse gratification, instant gratification. Even think about little kids. When they have access to those electronics all the time, it is instant gratification. Their brain is always working. I even see like 6-year-olds being concerned about how many likes they have on their Facebook page. 6-year-olds should not have Facebook pages, but I do know some that do, or they might have a TikTok account or an Instagram account. And they're putting their self-worth into how many likes that they have. We've also seen those that with histrionic and borderline personality disorders tend to be drawn to social media. They are more likely to post more often, and actually it might amplify the disorder because they're getting the likes, they are getting that attention, and then they just want more and more and feed off of those types of interactions they are receiving online. Unfortunately, when we're talking about personality disorders, they are going to be very difficult to treat. What we can do is we can focus on different goals, such as reducing subjective distress, changing specific dysfunctional behaviors, and changing whole patterns of behavior. In many cases, people that have a personality disorder only enter treatment because somebody else insists that they go to treatment. It's part of their personality. They do not believe that they need to change. That's just who they are. And unfortunately, when we're talking about personality disorders, it is part of their personality. Personality is enduring, it's deep-rooted, and it's going to be really difficult to change somebody's personality. So when it comes to treating these, they're not really well treated, but there are some different things that we can try. For example, we can attempt to do therapy. Sometimes this works. What we're going to focus on when we're talking about therapy, especially cognitive therapy, includes monitoring automatic thoughts, challenge faulty logic, and assigning behavioral tasks to challenge dysfunctional belief. Some of the issues we're going to see with traditional therapeutic techniques is oftentimes when we're talking about counseling, we're really encouraging a person to be independent. And if we're looking at psychotherapy, we might be encouraging that with somebody that's already too independent or possibly too dependent on other people. We've also found that patients that are either anxious or fearful, especially those from cluster C, are going to be hypersensitive to the perceived criticisms from the counselor. So they might have difficulties building a relationship because they see the counselor as being too critical of them. Some other options we have are going to be the use of medications. There are a lot of drugs that we can look at, but they have only found so-so results, especially when we're talking about borderline personality disorder. Some of the options that we can use here are antidepressant medications such as SSRIs, antipsychotic medications, and they have found that mood stabilizers can also help reduce symptoms over the short term, but over the long term, it really doesn't take care of the problem because like we said, it's part of the personality. It's going to be persistent. But if they have a comorbid disorder, taking an SSRI, for example, might help with some of those symptoms that we're seeing from either the anxiety or depression, but it is not going to take care of the borderline personality disorder. Treating other personality disorders, we have not seen a lot of treatment for cluster A and other cluster B personality type disorders. We have found that some low doses of antipsychotic drugs might have some modest results and SSRIs might be useful, but there have not been systematic controlled studies for treating people with either medication or psychotherapy, especially for paranoid, schizoid, narcissistic, or histrionic disorder. Remember, these are those people that are going to be highly suspicious of those around them and not very trustful, so they're going to be less likely to engage in a study in which they're monitoring that person's behaviors. We might have a little better luck when we're talking about cluster C disorders, such as dependent and avoidant personality disorder, and we have found some promising things that we can do in that front. Using active and confrontational short-term therapy shows improvement. Cognitive behavioral therapy also has had lasting gains when a person engages in that, and antidepressants and SSRIs can help in treating avoidant personality disorder as well. Next, we are going to move into psychopathy. Feel free to watch this video at home. I'm not going to spend the time right now to watch it in class, but I also have another video I'm going to share with you. It's a TED Talk on psychopathy. So when we first look at the first term of psychopathy, or what we're considering psychopathy, it leads back to the antisocial personality disorder that was first found in 1980 with the addition of the DSM-3. Initially, it was called psychopathic personality and is now referred to as psychopathy. I'm trying to get my, there we go. Cleckley made the most comprehensive early description in 1940s. He made this through the process of looking at multiple, very detailed case studies, and he found 21 core traits that he identified. When we're looking at prevalence levels, it is only about 1 to 2% for males in North America, and for females, it's much lower. Typically, when we're talking about psychopathy, most of them are going to be males. Some of the things that we have found on the checklist are superficial charm and good intelligence, lack of remorse or shame, poor judgment and failure to learn from experience, failure to follow any life plan, unresponsive in general interpersonal relationships, and pathological egocentricity and incapacity for love. So when we're looking at the dimensions of psychopathy, Robert Hare developed the 20-item psychopathology checklist revised, the PCLR, and he uses most of the same criteria that Cleckley found for the criteria of diagnosis, but it also included detailed interview and careful checking of past school, police, and prison records. So do they have a history of deviant or abnormal behavior? We can look at 4 different dimensions: interpersonal, affective, lifestyle, and antisocial. When we flip to the next page here, you will see what all of those look like. But I want to point out that lifestyle and antisocial dimensions are much more closely related to the DSM diagnosis of antisocial personality disorder. So what does that look like? So when we look at facet number 1, interpersonal, we look at superficial charm, grandiose self-worth, so really having a high evaluation of their own self-worth, and pathological lying. When we look at affective, facet 2, we see lack of remorse or guilt, shallow affect, and lack of empathy. When we go into factor 2, social deviance, we see facet 3, which is lifestyle. They have lack of realistic long-term goals. They are prone to boredom. In antisocial, they have poor behavior controls, early behavioral problems, and juvenile delinquency. That's why it is so important that we don't just look at some of the symptoms, that we also look at past school history, past community history, police records, to see if we have some of those facets that would fall within that antisocial personality aspect. Most researchers actually don't look at the DSM-ASPD. They are going to focus on the Cleckley and Hare's psychopathology diagnosis. Part of that is because there's a long research history, and it's not just going off of a quick checklist. It is also going deeper and seeing if there is a pattern of behaviors here. And when we're looking at psychopathology diagnosis, it is the single best predictor of violence and recidivism. So even after they're let out of jail, that they are going to engage in an act that could potentially end them back in prison again. Let's look at the clinical picture in psychopathy. We're going to look at the inadequate conscious development. So really, they may claim to have high moral standards, but they don't actually act on those high moral standards. So do as I say, not as I do type of mentality. The conscious development is going to be severely delayed or non-existent. So it's not there. They never really developed their conscious. And they behave as though laws do not apply to them. Laws apply to other people, but they don't apply to them, and therefore any act that they engage in, they should not be responsible for. Some other behaviors we're going to see is that they are going to be very irresponsible and impulsive. So they believe in taking what they want rather than earning what they want. They're also going to be prone to being thrill seekers. And they tend to have high rates of alcohol abuse or dependence on other substances, such as drugs. So oftentimes when we think about psychopathy, we might be thinking about serial killers. One that comes to mind when we're talking about some of these areas, such as superficial charm and likability, cannot understand love and give it to others. They're manipulative, exploitative, and they like to prey on other people's weaknesses, might be Ted Bundy. There's a really interesting video about Ted Bundy. I think it's called Bundy on Netflix, and it's kind of about his story. And really, Ted Bundy was a serial killer, and he confessed to killing 30 women within 7 states between 1974 and 1978. So within 4 years, he had killed 30 people. They actually believe the rates are probably much higher than that, and that his pattern of killing probably started earlier than 1974. For most people, Ted Bundy, he was good looking. He was handsome. He was charismatic. People liked him. And he was able to use many of these traits to exploit people and to win their trust, and therefore was able to take advantage of them. We can also look at genetic factors. So genetically, there is a strong link between psychopathy and passing that down. So about 43 to 56% of variants in the dimensions of psychopathy are related to genes. The remaining variance is explained more by non-shared environmental influences than shared environmental influences. So when they looked at a twin study of 3,687 twin pairs at age 7, they found that early signs of callous, unemotional traits in these children were highly hereditable. And I think that Hollywood likes to prey on this example of passing down traits. Think about any serial killer movies you may have seen, or movies that talk about psychopathy. Oftentimes, after they've already caught somebody, somebody else might still be engaging in those acts, and they end up finding out it was like a long lost daughter or something. I oftentimes think of Criminal Minds when I'm using this example, because there have been multiple episodes of Criminal Minds where we later find out they had a son or a daughter, a grandchild, where this genetic component was passed down, and they too end up becoming a psychopath. A couple of other things that we see in people that suffer from psychopathy are going to be abnormalities in selective attention and attention processing. They also lack general emotional deficits. So low on empathy, low on fear. Their brain doesn't respond in the proper way when viewing sad or frightening faces. The amygdala doesn't activate like it should. Another causal factor that we can sometimes see is that early parental loss, parental rejection, and inconsistency can also lead to higher rates of psychopathy. But I want to point out that alone, these are not sufficient as causal agents. So just because they lost a parent, their parents rejected them, they had inconsistent parenting, doesn't mean you're going to become a psychopath It just means that this is one of the features we often see in people that are psychopaths. When we look at how Ted Bundy was raised, he was actually raised by his grandparents, and they always told him that his older sister, or that his mother was actually his older sister. So his mother had him out of wedlock, and to avoid the embarrassment of having a child out of wedlock, the grandparents raised him and said that this is your sister, and never talked about it being his mother. It ended up actually creating a large amount of resentment towards his mother, and we often see many of his victims being female, and some of that resentment being acted out among his victims. So how do we treat psychopaths? Well, this is going to be very difficult, especially since they experience little personal distress, so they do not believe that they actually need treatment. Punishments have also been found ineffective. Oftentimes we see punishments that work for the general criminal population doesn't work for psychopaths, and actually can lead to increasing reoffending rates for psychopaths. So punishment in general doesn't work for them. So what are some of our options? Well, we haven't had a lot of chance in order to study this, especially when we're talking about 1 to 2% of the population. It doesn't give us a really broad pool. There's little evidence that any approaches have been very impactful. The one thing that we might see as having the greatest promise is going to be cognitive behavioral treatments. But even then, we only see really modest results. Some of the interventions we can include is increasing self-control, increasing self-critical thinking, and social perspective taking. We can also increase victim awareness. So what is this doing to your victims when you engage in these acts? Teaching anger management skills, changing antisocial attitudes, and if it's somebody that is suffering from a drug addiction, we can also look at curing some of those drug addictions as well, and getting them treatment in that way. These tools, the cognitive behavioral therapy, all of these other steps, typically are going to work well while they are in prison, but unfortunately, we are not seeing that carry over once they are released back into the general population. So it might work while we're in prison, but as soon as they're released, they kind of go back to their old ways. As I've said over and over, personalities do endure over time. That's why it's so difficult to treat personality disorders, because it is really part of their personality. But as people get older, they are going to be less likely to engage in that criminal behavior. But it really isn't going to change the personality. It just decreases the risk of violent or aggressive acts that they might engage in. So that is everything we have for this chapter. I apologize that we're not going to go into the next chapter, but what you need to do is complete the activity that we skipped on Thursday because we didn't have enough time. Watch the TED Talk on psychopathy, and of course, watch this PowerPoint. If you have any questions, feel free to leave comments below under the announcement that has this on there. Hope everybody has a good day.